What we're going to do in this session is to hear a bit from Craig and a bit from Jeremy. You know who Craig is because you've seen him speak on the platform. Jeremy Martin leads the Symphony Project that's been integrating data here in the UK. So we're going to hear a bit about the US perspective, but also about the UK perspective. But I'll let Jeremy introduce himself in more detail.
I think this is sort of informed both from what we have here from Craig and Jeremy, but also our observations of working in the area as part of McKinsey, and I've had the good fortune of being part of some of those initiatives. At some level, the story is really simple. We in NHS have a bane and a boon. The bane being we have almost the best data from anywhere in the world. So the boon being that we have the best data. And the bane being we have somehow, for some reason, still not managed to really get the most out of it, right? And I think what we wanted to focus on today's session was really on two parts. Learning from both the efforts and which Craig and Jeremy would talk about. One is what can we say about what is the benefits of putting together such data and how can it really be used? And the second is also then how do you go about the journey of putting it together, right? And I think that's the two-part focus we want to have of the session today. I would skip this, which is what we talked about. And just before I hand over to Craig, I think in just terms of framing, and Craig will give you more real-life examples of it, right? But one way we find it helpful of thinking about how can you really use data in the different ways is sort of this five-part framework in the sense of why do you really need this data? Because in the end, you want to achieve some system objectives, which should hopefully mirror some of these points, right? You can have for patient empowerment, for better care coordination, for improved clinical decision-making, better system design, and payment innovation, right? These five, I think, we think form a nice set of objectives. And underneath each of these, there are different ways of which you will ultimately end up using the same linked data set. You could use it to, for example, under patient empowerment, to access the medical record for which you really need the information from various settings, for monitoring patient goal setting and compliance. And if you talk about then similarly better care coordination, when you think about users such as event notification, somebody has ended up in the A&E, how can we inform the right carers about that happening? Or it's just simply supporting the care coordination, which I'm sure you have heard a lot about, and developing the tailored care plans, et cetera, right? Rather than going through all the details of these bullet points under each objective or use, I would, at this point, want to just hand over to Craig, and he would walk us through some of the uses that they have put this data to and what they have found as success factors. And then we'll come back to Jeremy.
So, I used to work at McKinsey and just learned how to be a good analyst and to spend a lot of time, trying to figure out strategy. And then when working with the family of entrepreneurs, they used to do what I call, ready, fire, aim, which is it's about immediacy of action. And it's been a very interesting, journey to kind of get the balance right. But I think in technology, it's really important because we can get trapped a lot by the complexity of data, the desire for perfect information, as opposed to asking ourselves, what kind of actions do we need to take, and how is information going to help guide those actions in a better way? And so that would be sort of the first perspective I'd lay out. And I think when you put that perspective in place, sometimes you can get a lot quicker answers than you might think. And then there's a lot of barriers because sometimes people want really good good information, but sometimes the actions are pretty straightforward of what you're doing. So again, if I break down in our clinical model, the key actions we're trying to take are to identify risk. You want when a patient comes in, we started to use something with a physician called the worry index. How worried are you about the patient? 1 to 10. Basic, but it's interesting because if they start to commit, then you start to see, well, how good was I at predicting whether this patient was worried? And I have a hypothesis that has not tested yet, that if you take that qualitative data and merge it with the quantitative data, you might get actually some better modeling, because I believe that the physicians have good judgment and the nurses have good judgment to pick up certain things intuitively that we might not get without any of the black boxes. But sort of driving it to action, I think, is critical. So you're identifying risk, and then all what care coordination is, it's a fancy word for activities designed to reduce risk. You're either reducing risk by changing the social environment, educating the patient, educating the caregivers, or you're making direct interventions, but you're trying to reduce risk. And so a lot of, as we build up these workflows, you always want to connect it to actions. And again, I think that's a principle that's worth thinking through. There's two of these pages that I put together which are about, the first is about workflows. And again, my thesis was that the value-based workflows look a lot different than activity-based workflows. And there's certain workflows that I think we're just in the early stages of figuring out. So for example, I'll give an example on the right-hand side, which is around panel management. So in a panel management, what you would like a physician to do is to have her look at all 404 or 450 of her patients and say, how am I doing with that patient group? Maybe finding opportunities, maybe having some comparison, but ultimately wanting to review that. And actually figuring out the opportunity identification. What we're finding is when physicians get activated and engaged, you get a whole number of very interesting hypotheses about what might work and what might not that you otherwise would not get if an analytic person is just looking at the data. So really engaging the front line is important. But now let me be honest. So we have a number of things around panel management that are pretty good. Let me just show one or two things. Sorry for flipping back. But a physician here can look at all of their data, and this shows what's happening on a number of different metrics, what the physician's results are, what the center's results are, what the market's results are, and we can even start to use pretty interesting visualization, to actually show, each of the dots being a patient. And this is an example of cost and risk, where each of the axes of the clock is risk, and the further you are to 11 o'clock, the higher risk you are, and the higher out you are on the axis, the higher cost you are. The lower in the axis, the lower cost you are. It's just you can do this with a lot of patient panel outcomes, whether it's diabetes or control of blood pressure. But the interesting thing about visualization is you can start to double click the dots and say, okay, now who's that person? And you double click, you see the patient's electronic medical record. And there's a number of ways with visualization where you can have a couple clicks below. But we're starting this tool for the clinicians to really explore how patient outcomes are working and connected to the front line. Now, I said I'd be honest, and the honest thing is when we put this toolkit out, it was nice and fancy and no one used it. There lots of people have had that issue. So then what did we do? Well, what we did is we started to book time on the physician's schedule and say, this is important. Instead of seeing a patient, you're going to have 40 minutes and you're going to review your outcomes. And now you're going to have a coach. So a coach is a center manager, a former center manager, who's been retro-trained to be a data coach. The center managers, though, have had a couple years where they've proven that they're very good at communicating with physicians. They're very good at telling you, doctor, you need to come in on time because you were coming 30 minutes late. And now a number of these center managers are sitting with the physicians and going over the data. Now you have to coach the coach. But the interesting thing is that when you start to invest, again, in engaging the physicians around that, it usually takes only 4 or 5 coaching sessions to really see a much different outcome. And we can see the different outcome because we can see every time a physician logs into this part of the timeline and know how much time that they're spending. So we're seeing, we really want the physicians to look at the data. But again, if you don't get the whole piece right, it becomes hard. So let me just talk about what, I'm not going in exact order, but a couple of pieces of the supporting system, if you will. One of them is around compensation, and this is a page that basically just lays out to the physicians. They got this in a memo form with their bonus and change in salary, which is here are the metrics that are the primary metrics that determine your compensation. It's going to be how much work you're doing, and work is the number of patients times risk, and that's it. There's no other activity about visits or volume or anything. It's how many patients, how sick are they? And if you have sicker patients, as measured by risk, you can see fewer patients. So at work, there's how a quality is measured by customer satisfaction. In the U.S., there's a bunch of HEDIS measures that are around quality outcomes that are regulated. And then there's cost efficiency, which is risk-adjusted as well. And what we tell the physicians is there are these metrics, and they are not going to change in the next 10 years. Now, the targets may change because the health economy may change, and we're going to have 30, 40, 50 other metrics that are double clicks and triple clicks below this that are going to educate you. But let's just start and say there are 6 or 7 that really matter. And now, for example, in cost, you need to probably have another 20 metrics to really understand all of those pieces. But we found when we put out 40 metrics to the doctors, they didn't engage. You have to kind of have it in a structured hierarchy. And then here with comp supporting it, there's no question that after our review process, there's been an increase in engagement around where the outcomes are. And so again, depending on the person who's using the data, really optimizing the environment around them, I think is important. And if we talk about the people that are using the data, let me just make 2 other points and then I'll pass it on, is that there are different levels of people in the system that are using data. So one of the biggest leverage points we believe is the medical assistants or community worker, where you can really, with technology today, teach them to be much more effective in terms of following guidelines and protocols. We have something that's on a tablet called MAQ, which is just the guidelines that someone might follow for a diabetic patient who comes in, or a patient with high blood pressure, or how to educate somebody who needs to go on a low sodium diet. We talked about the physicians. The other piece is that, again, with risk, is one of the biggest leverage points is actually the medical director and the interdisciplinary team. So they may pick out the highest risk population, and they're looking at managing them in collaboration with the physicians, and they need a whole different set of tools, versus the analytic group that's in the back end, looking to find out opportunities and pushing it all through. And as we've put together a number of these tools, many of them are off the shelf, or we've tried to build from what's available. So our dashboard, we basically looked at Google widgets and said, hey, the widget idea is great. So that's going to be the platform for how the electronic medical record will work. The physician can take each part of that, move it wherever they want, customize it, and turn on or turn off certain modules. When it comes to analytics, we've just used ClickView as a workhorse It's commercially available. You just build the data system. You teach all the market management team knows how to use ClickView themselves. And so it's completely self-service. There are a common set of reports that they use, but we also give them an opportunity to explore their own hypotheses. And then we also pair them up with an analyst for each of the markets. So, but it really, the desired model is do a little bit of the data searching yourself, because if you just rely on the analyst, you're not going to understand some of the connections involved. And let's just sort of train up everybody. And ClickView isn't perfect, but it's a good workhorse. The other piece is that we use a lot of email reports. So this is an example of hospital admissions per 1,000. It comes out Monday morning, 8 a.m. after the weekend data has been refreshed, and we're just tracking it with control charts, run charts, and there's a central repository. But again, the value of an email push is a lot different than just putting it on the warehouse for everybody to go look at, because then you get a couple chains going about what's happening in this market, what's happening with this market. And so I guess my point around information is, just to conclude, is design it around action. You all have a lot of data that is readily available, and I'm sure it can have impact. I think that's it. Okay, the other piece was just we also this is a screenshot of the iPhone application. So when our physicians are on call, we were finding that it was just too much to go and access patient information. If you're at a restaurant, you get on call, you don't necessarily have access to the full EMR, but you want access, let's say, to medications, problem lists. That's now available in a secure manner through the iPhone.
Thank you. Any questions for Craig before we move on to Jeremy?
I just wanted to get the emphasis right here, because I come from the acute sector rather than commissioning world, and I certainly have a sense that we don't use data enough for the sort of quality improvement. They're looking for opportunities with variation of outcomes, for instance, but we use it a lot for assurance.
A lot for?
Assurance.
Yeah.
The people who are buying our care want to know something, but it's not very useful for us in terms of that kind of weekly turnaround, that continuous quality improvement. That's what I'm hearing, is it?
The regulator, if you will, in Medicare has focused on the health plan level as opposed to the physician group at this point. So we may have the luxury for a couple of years of worrying less about the regulated environment and focus more around driving change. And so within any year, we're saying that there's a number of metrics and initiatives that we're looking at in terms of driving improvement, and those will be tracked on a weekly basis and ideally automated so that people are seeing performance in real time. One of the big issues that we had with improvement was that most of the data was claims-based. So we had our internal primary care data, and anybody who's an employee on our site, we could track that activity, but 80% of the costs are from what happens in the hospital or with the specialists or with pharmaceuticals. And so those go in claims that go to the health insurer, and we usually get those within 90 days. And a big problem was if you rely on claims, you're looking always 3 to 4 months backwards and saying, do I have a problem? And then when you know there's a problem, it's hard to steer the ship. And so we put a big initiative the last year and a half or 2 years to put what's called Sentinel Indicators. So now this graph, which is the hospital admissions, our case managers are working with the acute sector to make sure that we capture every admission and working with the payer to do it. In the state of Maryland, that's actually a lot easier because there's a automatic notification system, but the states that we're in, it doesn't happen. But now if we can get hospital admissions, and our capture rate is about 90% the first week and 95% after week 3. If you get hospitalizations and you can see what's happening around referrals, that's 70% of your costs. So you can see at the end of each week, okay, how are we doing? And that took that was all manual in the beginning, and we have not completely automated that, but it works. The windshield, if you will, is no longer completely muddy. It's there's just streaks of mud on it.
How you talk about clinician engagement as being really key to driving this kind of change and understanding about how patients flow through a healthcare system. And in your system, is it only the medical managers that see this, or is it every physician in every clinic that's seeing this kind of information?
Yeah, so I think we're getting better at the hierarchy of information and how much to show. When I joined the company, the physicians were seeing, there was really no filter of the information. They were seeing everything, but they didn't necessarily know how to interpret it, so it was having less impact. I do think the information needs are quite different, and I think for many systems, their impact may be greater if you're getting the right data to the case manager, or the people who are in charge of the interdisciplinary care teams. I'm not saying it's just the physician, but giving them access to most of the data, I think, is a good idea, but then filtering it in a way that they can see what the system thinks is the most important is critical.
I think mine was a similar question. I guess with me, getting the information out to the GPs, but more importantly, the GPs actually do something with it, but they didn't actually do something with it.
Yeah.
Because clearly we're not tied into sort of the same payment mechanism that you've got. So, I mean, it's getting over that there's how do you get over that culture?
The messages are all in the context of professional development. So we kind of go in and say to the doctors, we're all learning how to do this better, and so nobody knows how to do it perfect. And so that's how you're going to get your information. It's going to be, here are the facts, and then we're going to figure out for you as an individual, what are the 2 or 3 things you need to work on, and what are the 2 or 3 things the market or the center needs to work on. And there's a lot of improvement. We say up front, we're actually not trying to work on the outliers. We're trying to work to move 80% of the group to be at a level 4 or 5 of performance improvement. So it's within that context. So what I would, now I'm sure that won't apply 100% in your situation, but I do think what can apply in a principle is say, what's the strategy that we're going to adopt with the GPs around what type of changes we want overall? And then when we give them data, can it fit within that strategy? And what I see in the US is a lot of health insurers are great at sending the doctors lots of data and saying, here, doctor, you're in the 25th percentile, do something about it. And it's all these isolated messages as opposed to kind of bringing them in to the issue that we're all trying to solve. And again, I think we're getting better at it, but it feels like when we get those themes right, it resonates, and when we don't, it doesn't.
Can I just ask a really basic question? I'm afraid I don't understand your business model. Are you your system integrators working for the insurance company? Do you provide healthcare yourselves as well?
No, we're an independent physician group that has a joint venture with a health insurance company. So they have a minority interest, and then we agree that we're going to exclusively see Medicare Advantage patients of theirs. But it's an independent. We're not the health insurer.
No. But you're integrating the system on behalf of the health insurer.
Well, we have the majority share and they're the minority, so I don't think we're doing it on their behalf. Yeah.
I guess my observation is that's the capability we don't have, either providers or commissioners, So we've got data. There's data all over the place. Nobody's systematically sitting down and looking at it. And we do it on an individual basis. So I think for good clinicians, I think good GPs will look at their data. And as clinicians, we do very little bits of data, but the day-to-day management of individual patient groups and individual patient groups and populations is a bit that we just don't have the capacity in this country.
Yeah, so let me pick that up a little bit. So Humana as a payer, they do a lot of analytics. They have a great deal of analytic capacity and capability, but they are 2 or 3 levels removed from the front line. So I think they, from a system, are always frustrated that they see what's going wrong, but they don't know how to intervene.
Is it worth just restating a little bit about the care model? Is basically 36 ambulatory care centres that are GP-led, with a group of specialists in them,
Yep.
and receiving a capitated payment for the total amount of care. And if the patient goes to the hospital, it comes out of your
That's correct.
capitated budget, and if they don't, you keep the saving. And it sounds a lot like what we might have called a polyclinic in less controversial days.
But in the simplest of models, the system grew out of where Dr. James Chen, who is the founder, looked at data every day that was coming in. And when he saw issues, he would pick up the phone and call the doctor and say, Mrs. Smith, why is she in the hospital for 4.5 days? What are you doing about it? It was very action oriented. And so, I submit that process is actually not that difficult to put together. It's not a data issue. It ultimately becomes who's going to take the action when you identify these opportunities. And I've seen a lot in the past, a lot of work done on the data up front with less thought about who's going to run with the actions once it happens.
The Symphony Project, just a little bit of background about that first. So it's a collaboration between all of these different organisations in South Somerset. So the Clinical Commissioning Group, the local hospital, the DGH, with about 350 beds, it's a fairly small DGH, District Council, Adult Social Care from the County Council, the local Community and Mental Health Trust, York University that I'll come back to, the area team, and our neighbours in Dorset. So a lot of organisations around the table, and what we're trying to do is create a model of integrated care for people with 3 or more conditions. At the beginning of our project, we decided that we wanted to get some good data together, and this is why. We wanted to understand what were the current patterns of utilisation of all of our services across the patch, so primary care, hospital, community services, social care, and what was that costing us. And then we wanted to see if we could get any insight into what was causing those patterns of spend and utilisation. And from that then work out which groups of patients would be most effective to target first. From that then we wanted to be able to calculate what a shared budget might look like, a kind of capitated budget for that particular group of patients, and then have a baseline from which we could track how we're doing. So our local commissioning support unit, Southwest Commissioning Support, put this data set together for us. Now, we already had a data set that combines primary care data and hospital data because we had the United Health risk tool. I don't know if any of you have got that. That was a risk stratification tool that's still on the market, and a number of health communities around the country have it. But the advantage of that is it's a way of joining together the data from hospital and primary care and bringing the coding in from both sides. So the hospital codes and the primary care codes, which use different systems, the risk tool combines them into a single set of codes, which is called ETGs, or episode treatment groups. So that got us off to a good start because it enabled us to create a single set of clinical codes, which is really key, as you'll see later on. And then to that, using the NHS number, we were able to add the community hospital data, the mental health data, the hospital data, which was most already in there, but we added sort of non-PBR data. And the hard one was social care, because they weren't using the NHS number. So that was done using a fuzzy matching algorithm that the CSU came up with based on address, name, postcode, all of those sorts of things, which matched about 85% of the patients, and the rest they did manually. But we got there, and most recently we've added continuing healthcare. So all of that data is available at patient level, and it's all linked together and anonymised, importantly. And with that, you can do some quite powerful things, because also in the data you've got age, you've got sex, you've got what conditions they've got, you've got the ward of residence where they live. So you can do some quite powerful analyses. So this is the types of data that, this is a knit-in slide which are much better than mine. These are the types of data that we have in the data set. So you've got which patients there are and what their conditions are. You can see which provider did the activity and what activity was done. You can see how much it cost the commissioner, i.e. what was paid for that activity. Of course, all of those different sectors. We don't have outcomes in there yet. The time period was the complete year 2013-14 for all of the data. So it's not contemporaneous, but it's the most recent year, complete year. And we do it annually, because for our purposes, annual is fine. It wouldn't be, obviously, if you were using it for live purposes like you're doing in ChenMed. The IG issues we handled through a small group. So the CSU already had information sharing agreements in place with each of the organisations. So it was actually a relatively painless process for us to get the IG permissions in place to combine these data sets. The technology solution is Excel. And it covers, as I've described, all of those different aspects of the system. So how long did it take us? Well, the project started off in July 2012. That was the beginning. We had our first meeting in August. We called ourselves Symphony because we wanted something a bit different. It's not an algorithm. It's just supposed to symbolise lots of different parts of the orchestra working together. We started creating the data set the following April, and it took us about 2 months to do. It didn't take us nearly as long as we thought it would. It was actually quite a lot easier than we thought. So that's a good lesson to take away from today. The surprising thing was that no one had done it before. And we also, so we had the data set, but then we needed to know what to do with it. So that's where York University came on board. So we've been working with the Centre for Health Economics at York, and they've been doing all the analysis for us. So it's Professor Andrew Street, who also works on the Department of Health Year of Care programme. So in terms of the steps that we took to do this, this is a kind of generic 7-step process for creating a data set like this. We had a good project board, which is at senior level, which gave us the kind of permission and the headroom to do this. So each of them went back to their organisations and said, sort it out, we want to share this data. We had a small group that met every month that took care of the actual governance process and the actual process for putting the data together. The technical solution was Excel, as I said. We had a dedicated analyst working on this who went out and met all the organisations and actually put all the data together. And so it didn't cost a massive amount. They did it within their existing resources. And we didn't actually have to spend any money on this at all. So what did it tell us? So some quite powerful things. So this slide shows you what the relationship between age across the bottom and the number of conditions up the side. So obviously as you get older, you're more likely to have more conditions. So that's no conditions there. That's 1 condition, and that's 2, and that's 3, and that's 4, and that's 5, and that's 6, and that's 7+. So you can clearly see as you get older, you get more conditions, which I guess isn't a surprise. But what is interesting is if you look at the relationship between age and cost, and the number of conditions and cost, it's the number of conditions that is a much more powerful driver of cost than age itself. So there was a lot of talk about the frail elderly, but actually quite a lot of older people are quite healthy, and there's quite a lot of younger people who aren't. So if you look at the number of conditions, you get a much better predictor of cost than if you look at age. And if you add the two together, like you do on the right, it's only a tiny little bit more predictive. We thought we were doing a frail elderly project until we saw this, and then we changed it to add anyone over 18 with multiple conditions. This is another powerful slide which shows why you need to do multi-morbidity and not single disease pathways. So there's conditions down the left-hand side. The light blue is people who just have that condition. And the red is they have that condition plus one other. The green is plus two others. And that's plus three or more other conditions. So what you can clearly see is that not very many people just have one condition. So if you've got coronary artery disease, for example, diabetes, COPD, that's around 10% of the patients just have that, and 90% have at least one other condition. So that's quite a powerful message. Lots of these patients are on lots of separate integrated disease pathways. We put the whole lot together and you get something that's not very integrated. And this is cost by the number of conditions. So you can see here, as every time you add a condition, the cost goes up. What's interesting is that it's on a bit of a curve. So every additional condition that you add increases the cost by a bigger amount, which you might not necessarily expect. And then you can split it by setting. So this is all patients with diabetes, and then that's diabetes on its own down here. It's about £1,000 a year across everything. That's plus one other condition, plus two, plus three, etc. And going up the colours, that's primary care at the bottom. That big one there, no surprises, hospital inpatients, hospital outpatients, A&E, social care, mental health, community hospitals, social care, and continuing health care. So you can clearly see it's the acute inpatient costs here that are driving the increase in cost as people have more conditions. And if you can just move a little bit of this down here, say, massive potential to release resources. So that's a quick canter through the data. So a very different purpose to what Craig's been doing. But for us, it's been hugely influential in kind of shaping the direction of the project and enabling us to motivate people, because the data has been really good at getting clinical buy-in. And for once, in all the data projects I've been involved in, no one's argued with the data. They just go, wow, that's interesting. And then that gets them engaged in the project.
As I understand it, particularly in the States, there's quite a lot of work that's been done on prevention, looking at these groups and actuarially deciding which ones would actually be worth investing in terms of prevention because of the big gains that are subsequently made. Given that we've got a different information system, have you got any lessons to tell us about whether it's better to target in terms of prevention? Are there particular groups that you found where there's particular cost savings that can be made for some of these strategies? Because one of the dangers, I think, is to try and have a system which covers everything. It might be better to start by incrementally targeting particular groups.
It's a great question. I'll probably only be able to give you a partial answer. I think the folks who have multiple chronic conditions, sort of 6, 7, 8, I think the story is predominantly about secondary prevention, keeping them out of the hospital and substituting for the hospital with a lot of aggressive other care, including the center, home, what have you. I think the younger you get and the fewer conditions, the more you can focus around primary prevention. But the secondary prevention in these chronic conditions, there's usually a very large opportunity, and the reason why just is because of a design standpoint. Because the system isn't designed to do it, there's a lot of issues with coordination and handoffs. And so that it's just mainly because of design. So I think that's where a lot of the economic savings would be in the beginning.
That was fantastic. Thank you both very much for that.